Michelle Petri, who is going to talk about the new criteria. She graduated from Harvard Medical School, did her training at the Mass General and Rheumatology at UCSF, and then did an MPH at Hopkins. She heads the Hopkins Lupus Cohort, a longitudinal study of outcome in lupus. She's a member of SLE, and she's going to talk about the new criteria for systemic lupus erythematosus. We need to speak.
Is the mic working now? Good, okay. The SLE classification criteria were funded by the National Institutes of Health and by the Lupus Foundation of America. Many of us hope that someday we won't need criteria because there will be a laboratory test for lupus. But please think about this. If omics, genomics, proteomics, metabolomics are going to be our answer, we must give those researchers correctly classified patients. We have learned so much about the genetics of lupus through GWAS and family studies. In fact, probably now most of the major genes that predispose to lupus have been discovered. They tend to group into families, genes that involve immune complex processing, immune signal transduction, the interferon pathway. But I don't think we should make assumptions that the genes that predispose to lupus are necessarily the same genes that maintain disease activity. An example would be the interferon alpha gene signature. At Hopkins, you see our patients clearly segregate into two groups, those that have the signature and those that do not. Does the interferon gene signature, which clearly is one of the pathways that predisposes to lupus, maintain disease activity? And my answer to that is not. I want you to see here in the adjusted analysis that there's no association with a physician global assessment. But you're going to say, oh, but there is for SLE day. But remember that the SLE day contains serologies, low complement and anti-DNA. Well, that's not clinical activity, that's serologic activity. So if we modify the SLE day and take out of the serologies, there's no more association. So the interferon gene signature not only does not associate with same-day clinical activity, it doesn't predict flares either. Well, about BAFF, because we're so interested in BAFF or BLIS, aren't we, now that we have a biologic that will block it. Here is the distribution of BAFF gene expression in my patients. Now, it's really quite fascinating. BAFF gene expression correlates much better with disease activity than does the protein level in the blood. Let's look at disease activity. You can see even in an adjusted analysis a very strong association with a physician global assessment, even more so for the SLE day. And here we have a gene signature that correlates not just with clinical activity, but also with serologic activity. And wouldn't you want to know the BAFF gene expression when you're trying to pick a patient for belimumab? So these are the kinds of questions that weren't answered by the phase 3 studies. Now remember how we all bet for sure that rituximab should work for lupus, and those trials should have been positive, but of course they weren't. So here's another example of my being completely surprised. I thought that the plasma cell gene signature should be very important in terms of lupus activity because, of course, lupus is an autoantibody-driven disease and plasma cells are making autoantibodies. Here's the distribution, a really nice normal distribution in lupus. But here's the disappointing answer. Nothing for the physician global assessment, nothing for the SLE day. So again, I think lupus is always capable of shocking us and surprising us. Now, lupus, of course, is also affected by hormones. So do we need to have a different laboratory test for male lupus, female lupus? They really are different, aren't they? So men with lupus get more lupus nephritis and also have a worse outcome in terms of more renal failure and more myocardial infarctions. And autoantibodies do matter. In Baltimore, we found 3 clusters that inform on the clinical phenotype. First, we have anti-Smith and anti-RNP in Baltimore. That is an African-American cluster with a lot of renal disease. And we have found 2 different anti-DNA clusters. One is with Rowan law, where of course you see secondary Sjogren's, but the other one is with anti-phospholipid antibodies. This is a Caucasian cluster, where of course we end up seeing more thrombosis. Now you probably have different autoantibody clusters in each of your home countries, but doesn't that have to be taken into account as well? There are even differences in disease patterns. So about half of lupus patients have this pattern where their disease is always active. The patient who always has a platelet count of 80,000, for example. Half of lupus patients, though, do have the flare pattern where they're fine one day and flaring the next. We need different tests for these 2 clinical disease patterns. So what has changed since the 1982 ACR criteria? First of all, we are better clinicians. It's not all going to be doing a CT scan. We matter. We're much better at differentiating the different cutaneous types of lupus. We're much better at understanding the different neurologic manifestations. Of course, we have better measurement techniques. The urine protein to creatinine ratio is a really good example. We are more sophisticated in our ability to subtype autoantibodies, for example, anti-beta-2 glycoprotein. We recognize the importance of low complement, which was one of those glaring things that was left out in 1982. And we so appreciate lupus nephritis that we think it should be a stand-alone for classifying lupus. Many people have tried since the 1982 criteria to find a pathway forward, and that includes the committee headed by Mark Hochberg that added anticardiolipin but got rid of the LE cell. The Cleveland Clinic actually devised weighted criteria using a Bayesian theorem. Remember, the weighting is to try to emphasize the lupus nephritis. The Boston group went one step forward by including anti-phospholipid antibodies and including renal pathology. Again, a clear message. Lupus nephritis is so important, it should stand alone. Edworthy introduced modern statistical modeling using recursive partitioning. Several of the things that Edworthy did, you will find out that the SLIC group did as well. Splitting the immunologic criterion into its component parts and splitting the hematologic criterion into the separate cell lines. What should be the gold standard? Jim Fries published a very important paper that we took to heart and followed. The gold standard should be established by lupologists. We had to use consecutively treated patients and multiple institutions internationally to avoid bias. We had to have real control populations, all the other rheumatic diseases that you and I see that might be confused with lupus. We had to define everything with precision. And very importantly, once we derived the criteria, we had to validate them on a completely independent data set. First, we made the derivation set. you can imagine the amount of work to find 716 patients from 25 sites. I hope you're impressed by the breadth of the control group. It actually wasn't easy to arrive at a consensus diagnosis. You know many of the people in SLIC, and you are not surprised that we don't always agree. So we actually had to have smaller review panels to reach consensus on some of the patients. Then actually, Graciela Alarcón, our chair, was in charge of a subcommittee. After we identified the univariate analysis, she and her committee decided on a reduced set of variables to bring forward into the recursive partitioning model. Recursive partitioning is a classification tree. It's the current way of trying to devise classification criteria. It can be very complicated, but I think one of the things that SLIC did very well was to derive a relatively simple rule. We had to redefine the rule in small group settings, and here I can't thank Ian Bruce and David Eisenberg enough for helping to arrange these small group meetings. And at a final SLIC meeting, we had to take some votes on issues in which there was great disagreement. And my disclosure here is that I lost on every single vote. But I accepted a long time ago that there's the wisdom of a committee. So the vote was to exclude anti-C1Q. I'll later show you some data on anti-C1Q, though. The vote was to exclude a constitutional clinical criterion of fever and lymphadenopathy, and to include joint line tenderness with morning stiffness under the arthritis criterion. Now, the validation set was 690 completely different patients from 13 of the international SLIC sites. Here, we really need to thank Joan Merrill, because some of the tests we included in the validation set, she did in her laboratory, such as the anti-phospholipid antibodies. And I also want to thank Rheumatology Diagnostics Laboratory and Inova to help defray the costs of some of the other assays, because we couldn't have missing data. We had to do all the assays on every single patient. Our statistics were Kappa statistics and McNemar's test. Here is the SLIC rule. It's based on two very important principles. The first is that lupus is an autoantibody-driven disease. And therefore, to classify as having lupus, the patient needs to have at least one clinical criterion and at least one immunologic criterion, adding up to a total of 4. So we kept that rule of 4 to make your life easy. But the second principle is that lupus nephritis is so important that it can stand alone in the setting of ANA or anti-DNA. For the pharmaceutical and biotech companies in the audience, this should greatly help you in enrollment in your lupus nephritis studies. Let's walk through the different criteria, and I'll try to highlight the differences. The first one is not just acute cutaneous lupus, but subacute is also included. As you know, 50% of patients with subacute cutaneous lupus have SLE, and of course it was left out of the original criteria. You remember there it was malar rash or photosensitive rash. The second one is chronic cutaneous lupus, no longer limited to discoid lupus. It includes all the different subtypes of chronic cutaneous lupus. And here we're indebted to Vicki Worth and her colleagues who participated. Oral and nasal ulcers are the same, but here's something that wasn't in the ACR criteria, non-scarring alopecia. Some of the older members in the audience will remember it was part of the ARA criteria, which predated ACR. Here we do not mean a patient complaint of hair loss or hair fall. It must be objectively determined on exam, either broken or missing hair around the frame of the face or diffusely thin hair. Synovitis, remember, we included tenderness with morning stiffness. Serositis is the same. Renal, of course, includes the spot urine protein to creatinine ratio, not just 24-hour urines. And neurologic has been completely revamped. Of course, seizures and psychosis are there, but now you see mononeuritis multiplex, myelitis, peripheral or cranial neuropathy, and acute confusional state. Remember that Edworthy divided the hematologic criterion into its component parts. That's what our recursive partitioning did as well. So you see hemolytic anemia, leukopenia or lymphopenia, and thrombocytopenia separated. And you only need to have them once. Do you remember the fine print in the ACR criteria where you had to have something twice? Here, of course, you must play by the rules. It must be attributed to lupus and not to a drug or an infection. Now let's turn to the immunologic criteria. Of course, we're stuck with the ANA. But just as Edworthy split into the components, we split the immunologic criterion into component parts. Now for anti-DNA, there is a caveat. ELISA assays have a lot of false positives at the low level. So if ELISA is being used, the titer must be twice the upper limit of normal for that laboratory. Anti-Smith is a standalone. Antiphospholipid antibodies now include anti-beta 2, and very importantly, the IgA isotypes. We found in our SLIC exercise that the IgA isotypes are actually quite specific for lupus. Low complement is there, finally. You had to wait 30 years, but it's there. And now you jumped ahead and you saw the direct Coombs test, and you're asking why. Well, in the univariate analysis, the direct Coombs test was very specific for lupus. And the great majority of lupus patients who have a direct Coombs test will never manifest an autoimmune hemolytic anemia. So we capture it here. If the patient had an autoimmune hemolytic anemia, though, it must be captured on the clinical side. You're not allowed to double count. Now, let's look first at how these criteria performed on the derivation sample. And you should expect that they would perform quite well because that's where they came from. So yes, there was very good sensitivity, equal specificity, and a great reduction on misclassified cases. But that can't be enough. Remember Jim Freeze teaching all of us that it's not enough to derive them, you must test them on a completely independent validation set. So here are those results, and you can see a huge difference in sensitivity, but a drop-off on specificity, still a reduction on misclassified cases, but there is no difference statistically between the SLIC criteria and the previous ACR criteria. Now, what do you do when there's no difference? We thought that the only answer was to invite you to use both of them, ACR or SLIC. And we think that that's our advice both to you in clinical practice and to industry as well. Now, I promised to show you some of the anti-C1q data. Anti-C1q is not specific for lupus, but it is predictive of lupus nephritis. And unlike anti-DNA and complement, it does track with renal activity using the SLIC renal activity score. As good anti-C1q kits are approved by our regulatory agencies, I do think we will be using this autoantibody more routinely in practice. Now, in the United States, we do have an FDA-approved assay for complement split products bound to red cells. It has been shown to help to differentiate lupus from controls and also lupus from other rheumatic diseases. There's some overlap with undifferentiated connective tissue disease in APS patients. This is not being widely used, was not available at the time of the SLIC exercise, so those are some of the reasons that this was not included. Now, many of you are going to ask a question, which I'm now going to anticipate, which is, why didn't we add everything to the neurologic criterion that is in the ACR neuropsychiatric case definitions? We would have had, obviously, a much longer list. This is the list of what we did add, but your favorites may not be there. I wanted to show you John Hanley's data representing the SLIC inception cohort. When the ACR neuropsychiatric case definitions are used, 3 of the 4 most frequent ones are not only not specific for lupus, they may not have anything to do with lupus itself: headache, mood disorder, and anxiety disorder. So let's think a little bit about headache. Headache truly due to active lupus is vanishingly rare. In fact, it's the item on the SLE day that we hate the most and don't want anybody to check. Most headaches in women with lupus are migraine physiology, and unfortunately, we may actually worsen this by some of the other medications we prescribe, especially SSRIs for depression, but also proton pump inhibitors for dyspepsia increase migraine headaches. Then, of course, we have some rare things that can happen, but usually headache has nothing to do with lupus. And in fact, there are several studies that have proven this, that headache is not increased in SLE compared to controls. What about mood disorders? Remember, that was number 2 in the SLIC inception cohort. Depression is very common in lupus, and I think our attention has been drawn back to it because of the suicidality warning in the belimumab label. I think depression is very important in and of itself, but also because it is the strongest correlate of cognitive impairment in lupus. Although I wish I could say confidently that it's completely separate from lupus, work that Tammy Utset did suggests it may have some relation to lupus. It's much more common in patients who have had other specific neuropsychiatric problems from lupus, and it's also more common in lupus patients that have secondary Sjogren's. And we know, for example, that Rho can get into the brain. Psychosis we kept, even though it's much less common than before. There's great interest, isn't there, in autoantibodies and finding an autoantibody for neuropsychiatric lupus manifestations. The SLIC inception cohort did find an association of anti-ribosomal P with central events, with diffuse events, and with psychosis. So why don't we have that as one of the immunologic criteria? It's because rarely was it available at the different SLIC sites. Anti-ribosomal P has a strong basic science behind it. It actually binds neuronal surface proteins and can induce their apoptosis, so it likely is important. Seizures were kept, but again, seizures are much less frequent in current cohorts than back in 1982. And of course, seizures do have a differential diagnosis, don't they? So remember to count under the neurologic classification criterion. You must attribute it to lupus, not to APS or to one of these other causes. John Hanley, on behalf of the SLIC group, has just found that antimalarial use may prevent seizures So even another reason to have everybody with lupus on hydroxychloroquine. But here's one of the ones that you may have wanted there. Cognitive impairment is very common in SLE. In our brain connection study, we found it was present at the time of diagnosis for 60% of patients mildly, but for 19% moderately. The good news was it tended to improve over the next 5 years, during which the brain connection patients had serial ANAM testing. As I mentioned, depression was actually the most important associate, and it wasn't depression diagnosed by the treating rheumatologist, it was depression ascertained by the Beck Depression Inventory, showing me that we often miss it in our interactions with patients. Depression is very common, but we in the brain connection study found no association with anti-NR2 of either depression or cognitive impairment. But imaging studies turned out to be very important in the brain connection study. At the time of diagnosis, surprisingly on brain MRI, brain atrophy was the most important, not those small white matter lesions. But on brain PET, what we found was white matter inflammation to be a marker of SLE disease activity. Now, obviously, classification criteria cannot include brain MRIs or brain PETs, given the huge cost. But someday, maybe this is how we're going to classify patients as having CNS lupus. One thing we did include was myelitis, because there's been tremendous progress in understanding myelitis in lupus. First of all, it's not transverse. In lupus, it's longitudinal. And secondly, there are two different types. The gray matter type is the most severe. These patients present with a prodrome of fever and urinary retention in the emergency department and are often sent home with a diagnosis of urinary tract infection. But then they come back, usually within 24 hours, having infarcted the gray matter. The problem is, once you infarct gray matter, you never get it back. So that's why this is so devastating. Even if in the emergency room they were absolutely brilliant and did a lumbar puncture, the CSF formula looks infected because there's a high CSF protein and high CSF white blood cells. You would have to pick up on the fact that longitudinal myelitis is even a possibility and order a spinal cord MRI. Then you would hopefully start intravenous methylprednisolone. The second type of myelitis involves the white matter. It often can occur in the setting of otherwise quiet lupus. In multiple sclerosis, it's sometimes called Devic syndrome or neuromyelitis optica. In lupus, there is an association with NMO antibodies, but also with anti-phospholipid antibodies. Here, though, the anti-phospholipid antibodies are acting through their inflammatory role, not their thrombotic role. Here's an example of the devastation of longitudinal myelitis in lupus. Now, many of you are upset that stroke isn't there, but stroke due to active lupus vasculitis is vanishingly rare. About half of strokes in people with lupus are due to APS, and the other half are due to traditional stroke risk factors, but also due to homocysteine. Ischemic stroke in lupus is actually somewhat rare. The risk factors are very clear: lupus anticoagulant and hyperlipidemia. Now, there's some things that aren't even in the ACR neuropsychiatric case definitions because they weren't really recognized back when Matt Liang headed that committee. And one of them that we are all going to encounter sooner or later is PRESS, posterior reversible encephalopathy syndrome. Now, it's not specific for lupus, But when it does occur in lupus, it tends to occur in newly diagnosed patients with very severe nephritis, and it can be devastating in terms of the neurologic sequelae. Another manifestation that was not included in the ACR neuropsychiatric case definitions is small fiber neuropathy, again because it wasn't well recognized then. This turns out to be one of the most common causes of peripheral neuropathy in lupus. And because both cranial and peripheral neuropathy are included in the SLIC neurologic criterion, this would be included. There are actually two different types, one involving the distal axon and one involving the dorsal root ganglion. Those of you who also take care of HIV patients will have seen something similar in HIV. Now, this will be missed by EMG nerve conduction study because only small fiber nerves are involved. It's actually diagnosed by skin biopsy. A skin biopsy distally, if it's a distal axon form, or of the proximal thigh, for example, if it's a dorsal root ganglion form. And the skin biopsy is immunostained for PGP 9.5, and then the intraepidermal nerve fiber density is calculated. Now, I wish there was a specific treatment for this. There isn't, but it's something new in neurologic lupus. So to close, I presented the classification criteria for you. They were not given the ACR or EULAR label because it turns out to get those labels, you must have funding from ACR or EULAR, and we were independent. Remember that I've shown you that statistically they are equal, so I want you to use both. And I will never tell if you use the SLIC criteria to help you with diagnosis. Thank you very much for your attention.
Hi. Unfortunately, we don't have time to make some questions, and I hope if the audience can talk to Dr. Michel after this session. Thank you.